The first witness to give evidence in court today is a nurse, who cannot be named due to reporting restrictions. She explains she was a shift leader at the Countess of Chester Hospital neonatal unit in June 2015. The nurse explains to the court the different types of care that would be provided to babies arriving in the neonatal unit. The nurse is now being asked questions on Child C. A reminder that none of the children listed in the charges can be identified, so a naming system of baby child A to baby child Q is being used by the press. The nurse said back in 2015 she was not sure she was the one allocating the designated nurses to the babies for that shift, as the allocation system was in the process of changing. She said she remembers Sophie Ellis was the designated nurse for Child C that evening. She says Sophie was, quote, a very competent nurse, having come through the neonatal unit as a student nurse. The nurse remembers there being no clinical concerns for Child C at the start of the shift. The nurse also recalls Lucy Letby was on duty that night, looking after at least one different baby in room 3. The nurse said she had, quote, concerns over respiratory distress for that baby at the start of that night shift. He was grunting and such symptoms had not been present prior to that. The nurse asked Lucy Letby to increase the observations for that baby from 2 hourly to 1 hourly and called a registrar in. The prosecution asks the nurse about Child C's collapse at 11:15 p.m. She replies, quote, I do not remember where, but I was not in nursery room 1. She recalls, quote, a shout for help, but does not remember who called it. She entered room 1 and saw Melanie Taylor and Sophie Ellis, and a Neopuff device was being administered. She noticed Child C was not breathing and the heart rate was very low. The Neopuff gave Child C chest movement, but he did not breathe himself. Child C had a mottled skin appearance, the nurse recalled. She remembers a crash call being put out and recalls Lucy Letby being present, but does not recall when Letby entered the room. She recalled Sophie Ellis was, quote, becoming emotionally upset, and the nurse said she advised her to step outside. The nurse remembers resuscitation efforts were made and Child C was baptised and overseeing palliative care to make the baby boy more comfortable before he died. The prosecution asks, quote, whose responsibility is it to ensure the memory box is made and who takes care of it? The nurse replied, the designated nurse at the time, if they're able. The nurse said Melanie Taylor took over as designated nurse and partly arranged the memory box. The nurse explained she asked Lucy Letby to focus back on a baby in nursery room 3, but Letby went into the family room a few times. The nurse recalled asking Lucy Letby to leave the family to Melanie Taylor. The nurse tells the court Letby did not have any designated duties to be in the family room and told her more than once not to be in the family room. Ben Myers, KC, for the defence, is now asking the nurse questions. Mr. Myers asked the nurse how busy the unit had been between 2015 and 2016, and from a statement she had made, there were more babies arriving into the unit and more, quote, intensive unit babies arriving. Mr. Myers said the number of intensive unit babies arriving seemed more than what Arrow Park, a tertiary centre, had. Mr. Myers says the nurse, in her 2018 statement, said a ward manager was, quote, fighting for more nursing staff for the Countess of Chester Hospital. We sometimes weren't meeting staff guidelines for ratios. The nurse replies that was the case across the nursing network. The nurse agrees it was, quote, not an ideal experience for staff. Mr. Myers replies, and not an ideal experience for babies? There will be a danger of a knock-on effect. The nurse replies, just because the amount of babies increased does not mean we were not compliant on any shift. The nurse said she did not say staff were struggling to cope, after being asked about her statement saying staff were missing breaks during busy shifts. Mr. Myers asks about Child C, asking if he was in a, quote, potentially fragile condition. The nurse agrees. Mr. Myers says that due to his size and prematurity there was a risk he could die. The nurse agrees. The nurse said she could have changed the staffing allocation for designated nurses for that night shift had she wanted to. She says she does not know whether Sophie Ellis had looked after a baby as premature as Child C before, but had confidence in her as Melanie Taylor was there for support. She says she does not recall if Lucy Letby had asked her to spend some time in that room 1. Mr. Myers asks about Child C's collapse. The nurse says she was not in room 1 at the time, but saw Sophie Ellis and Melanie Taylor in that room, attempting to assist Child C's breathing with the Neopuff device when she arrived. The nurse says an initial crash call was put out, followed by one for a consultant. Mr. Myers says the police statement refers to, quote, "I think Lucy Letby was in the room by now." The nurse said she made the statement 3 years after the incident and could not recall precisely when Letby had entered. Mr. Myers asked the nurse if she was the one to take an upset Sophie Ellis aside and get her to step down from duty for that time. The nurse agrees. The nurse said Lucy Letby returned to looking after the other babies after a number of askings not to be in the family room, as the nurse and Melanie Taylor were looking after Child C and his parents following the collapse. Simon Driver, for the prosecution, rises to ask the nurse more questions. The nurse is asked if, given the busy shift, the quality of care was in any way diminished for Child C. The nurse replies, no. The nurse adds she would have allocated Sophie Ellis to look after Child C as the designated nurse, with Melanie Taylor supervising as she believed her to be competent. The nurse said she believed another baby on the neonatal unit, the one Lucy Letby was designated to look after that night, should have had more care, including a septic screening, as the nurse believed that child was the most concerning to her that night. The nurse says from her police interview, she, quote, believed Sophie Ellis and Melanie Taylor were in room 1 with the Neopuff device when she arrived. The court hears the response from police was, okay, followed by the nurse saying, quote, but I 100% couldn't tell you, which the prosecution say meant she was not 100% sure. The next witness to give evidence is Dr. Catherine Davis, who in June 2015 was a paediatric registrar at the Countess of Chester Hospital. The court hears she had been working night shifts for the night Child C collapsed and the previous night. Dr. Davis says she does not recall a previous night shift, but from her nursing notes on the night shift of June 12th to 13th, she recalls the observations for Child C at 9:20 p.m. on June 12, 2015. The notes include, quote, suspected sepsis and jaundice on a list of ongoing problems. The latter is, the court hears, quote, very common in premature babies. Dr. Davis added that at that point there had been no desaturations or bradycardia. Child C was NBM, nil by mouth, due to bilious aspirates. Dr. Davis's notes include simple drawings of the lungs and abdomen. The lungs had, quote, good air entry with the abdomen soft and not discoloured. Dr. Davis says there was, quote, nothing worrying about Child C's tummy at the time, noting there would likely be air in the stomach due to him being on CPAP. We now have prosecutor Philip Astbury asking questions in relation to the collapse of Child C. She said she would have received a crash call bleep and was relatively close to the unit when it happened. She remembers, quote, a lot of activity when she went into room 1. She remembers there being a senior nurse present, but beyond that is not sure of who was there. Dr. Davis's note is presented to the court, written at 1:30 a.m. on June 14th and timed retrospectively. The note said she arrived at the unit in less than 1 minute after the crash bleep went off. A Goodell airway in situ was noted, with chest compressions in progress. Dr. Davis noted occasional intermittent gasps. Dr. Davis said she believed Child C looked pale when she arrived. Dr. Davis explains chest compressions would stop briefly to detect if Child C had a heart rate. Chest compressions were restarted and the on-call consultant was called urgently. Dr. Davis attempted to intubate Child C but was unable to do so as Child C's vocal cords were swollen. Dr. David tried again with a similar tube twice but was unable to intubate. A list of drugs was administered, including several doses of adrenaline. The next note was at 2 a.m, following a, quote, prolonged attempt at resuscitation. Dr. Davis, quote, it became obvious that we were not winning, we hadn't got a heart rate. The failure to resuscitate was very unusual, as premature babies usually had some response to resuscitation efforts, even if it was temporary. Dr. Davis tells the court Child C had no response. Dr. Davis said she was later called by a family member of Child C to be informed they had believed Child C had died, and she explained she would have carried out the necessary observations and verified the baby boy had passed away. Ben Myers KC for Letby's defence is now asking Dr. Davis questions. He says that Child C was, quote, on the limit of what the Countess of Chester Hospital could treat, being at 800 grams birth weight. Dr. Davis agrees. Mr. Myers is referring to Dr. Davis's note on June 12th, where a raised CRP reading is noted, which he says is a potential marker for infection. Dr. Davis agrees. She also agrees child C is at increased risk of abdominal problems due to his prematurity. Mr. Myers asks about the bilious aspirates. Dr. Davis says any such aspirates of any colour are a cause of concern. Mr. Myers asks, it's a red flag for a problem, isn't it? Dr. Davis replies, yes. Dr. Davis said she would have examined the bigger picture in that child C handled well, had a soft abdomen and there were bowel sounds. Quote, there was no suggestion we should do anything different. Dr. Davis said there were no other signs of NEC. Mr. Myers said the bile aspirates could be a symptom of something else. Dr. Davis says child C was examined for other symptoms but was still well, and his bowels were not yet open. Dr. Davis adds, quote, he had a lot of challenges, but he was doing well. Mr. Myers asks, he had the potential as a small baby to deteriorate rather rapidly? Dr. Davis replies, yes. Dr. Davis said child C was not getting sick despite the readings of dark bile aspirates. Quote, it is not something we should ignore, it's something we should keep an eye on, but I don't think there was anything else we should have done. She adds that dark bile is not normal but not uncommon in premature babies. Mr. Myers said child C was not seen by a consultant until 3 days after he was born on June 13th, and quote, the appropriate step would have been for child C to see him before then. Dr. Davis said such a step would have been discussed prior to June 13th. Mr. Myers, for the defence, said the collapse of child C happened before Dr. Davis had a chance to review him. Dr. Davis agrees. Mr. Myers refers to the circumstances of child C's collapse. He asks if a tertiary unit would have had advanced practitioners capable of intubating a baby. Dr. Davis said they would have had more staff available, but cannot comment on Arrow Park. She says from her experience in a tertiary centre, there would be advanced nursing practitioners, but they would not work night shifts. Dr. Davis said there would be a risk-benefit discussion for whether a baby would be in a Level 2 unit at the Countess of Chester Hospital or a Level 3 unit such as Arrow Park. She said there would be risks in transporting a baby in an ambulance to that tertiary centre. She adds bed availability would not be an issue as they could always transport out of the region if necessary. Dr. Davis said at the time she arrived in room 1, the nursing staff were doing everything they could do. She says that the decision to intubate was not necessarily the right or wrong thing to do, but had its advantages. The intubation period would have lasted about 30 seconds, as during that time child C would not have had the Neopuff bag support. Dr. Davis said after those 30 seconds, efforts to resuscitate using the Neopuff would resume. Dr. Davis said, despite the resuscitation attempts, child C would have had a huge amount of time without a heart rate. Mr. Myers asks, did the delay in intubation cause any difficulties down the line? Dr. Davis replies, no. Philip Asprey rises to ask if Dr. Davis has seen a collapse that sudden or unexpected in a child like child C before. Dr. Davis replied, absolutely not. She adds that from her experience she had seen a lot of babies with significant abdominal issues and had dealt with babies with NEC, but they didn't behave or die in the way that child C did. The next witness is Dr. John Gibbs, who in June 2015 was working at the Countess of Chester Hospital as a consultant paediatrician and had been working at the hospital for over 20 years. He says he had seen child C a few times during the first few days of his life, and had carried out a review. Quote, there was no particular concern about child C, despite there being gastric aspirates, and while being small even for being premature. There was, however, risk of conditions such as NEC. He said such aspirates were, quote, not uncommon as gastric acid could accumulate in the stomach, and Dr. Gibbs recommended an antacid be given for the stomach. He says Dr. Ogden's note of the abdomen being, quote, soft and not distended is a very reassuring sign. Dr. Gibbs said if the aspirates got steadily larger, that would be a concerning sign and a symptom of NEC. It was decided, Dr. Gibbs said, to monitor the aspirates and hold off giving feeds at that time. He said if the aspirates got larger or came with vomiting, then an abdominal x-ray would be carried out. Dr. Gibbs said he carried out an ultrasound scan of child C's head, which was recorded as, quote, normal at 3:55 p.m. on June 13th. He was next involved with child C as the on-call consultant, having received an emergency call at about 11:28 p.m. A note is written retrospectively by Dr. Gibbs at 12:30 a.m. He said when he arrived, efforts were being made by staff to resuscitate child C. He said child C, quote, looked pale and mottled, which he said was, quote, not uncommon in babies in cardiac arrest. The notes show Dr. Gibbs intubated child C to provide more effective ventilation. He adds that ventilation can also be obtained through the NeoPuff device. Dr. Gibbs says that babies experiencing a sudden and unexpected collapse would normally be expected to show some signs of responding to resuscitation efforts, and it was, quote, unusual child C did not. The resuscitation attempts were said to have failed after 40 minutes. Dr. Gibbs said it was, quote, standard practice for attempts to cease after 20 minutes, but staff would carry on for a little longer in the hope of the baby responding. Resuscitation efforts continued after the 40-minute point while the priest arrived to baptise child C. He said, quote, surprisingly there were some minimal signs of life in child C and he was not sure what to do, as it was unexpected. He was not sure why a feeble heart rate and breathing gasp were being recorded for child C. He relayed to the parents that, due to the prolonged time without oxygen, the chances of child C being brought back without profound brain damage were, quote, extremely remote. Dr. Gibbs said it was planned to offer child C palliative care for his final hours. Dr. Gibbs said he could not provide a cause of death, so subsequently contacted the coroner's office. Dr. Gibbs said a debrief was carried out for child C's fatal collapse on July 2nd, in which the circumstances were discussed. It was noted in a summary of the debrief, child C, quote, did not seem unwell, was, quote, active, kept pulling out NG tubes. An infection was suggested, but child C was on antibiotics. Dr. Gibbs noted in the debrief the collapse was not related to the feed, which was administered shortly before the collapse, as he said he could not see how the administration of 0.5 ml of feed could lead to a cardiac arrest. The resuscitation was performed, quote, technically well, and the team worked well together. Dr. Gibbs explains the context from the notes was that the staff had done everything they could to save child C. Dr. Gibbs said it was not possible to rule out a pulmonary embolus, a blood clot which breaks off from another part in the body, blocking lung circulation. Another theory was toxins from medicine administered. The post-mortem had been held at this point, but the results were not available. Dr. Gibbs said he wants to clarify that he is not blaming the parents for requesting to allow child C to be baptised and the wait that followed for a priest and a vicar to arrive. He said the problem was that child C's heart and lungs restarted following the token efforts to resuscitate, and he could not think why that was the case. Quote, whatever catastrophic event had happened to child C had reversed, or begun to reverse. I don't understand that from a natural disease process. He said it was right the parents requested for a priest to arrive for baptism. He adds the difficulty was that child C's heart and breathing restarted following that. The trial is now resuming, with Dr. John Gibbs giving evidence. Ben Myers KC, for Lucy Letby's defence, is now asking Dr. Gibbs questions. He asks about the staffing arrangements in place at the hospital at the time. Dr. Gibbs says at the time he is fairly sure the paediatrician of the week on a rota would cover the children's ward and the neonatal ward. They would not have any planned clinics for that week. Other consultants would cover during the night, as the paediatrician could not cover a 24/7 week the court hears. Dr. Gibbs said the workload would depend on need, and consultants would spend more time on the paediatric ward as there would be much more turnover there than the neonatal unit. Mr. Myers, for the defence, asks if Dr. Gibbs would agree that consultant cover was stretched during 2015 and 2016. Dr. Gibbs said more consultants arrived after June 2016, but they had been requested for several years. The consultant cover at the time was, quote, fairly typical for a level 2 unit the court hears. Dr. Gibbs said the addition of 2 consultants had been planned for many years. He said every speciality wants more staff, as did a lot of hospitals, given the context of the staffing pressures of the NHS overall. We wanted to increase the number of staff so we could reduce the number of hours. Mr Myers for the defence says the two consultants arrived after the Countess of Chester Hospital was reduced to a level 1 neonatal unit in June 2016. Dr Gibbs says that is the case, but the two were not linked. Mr Myers asks about child C being on the limit with birth weight. He asks whether it would be, quote, almost inevitable child C would have faced complications, and asks if in hindsight child C should have been cared for at a tertiary unit. Dr Gibbs replies, that depends on what causes sudden and unexpected collapses, leading to his death. Mr Myers asks, taking that aside, should child C have been cared for at a tertiary centre? Dr Gibbs replied, no. Mr Myers asks about the bilious aspirates that were found. He says if a baby is producing dark bile, is that a concern? Dr Gibbs replies, it raises some concern, yes. Mr Myers responds, it's potentially serious, is it not? Dr Gibbs replies, no, it comes from acid reflux. Some normal premature babies produce bile aspirates. He adds that is why an antacid was administered to child C. Mr Myers produces a nursing note from Yvonne Griffiths, which refers to, on June 12, 2 mils of, quote, black stained fluid plus bile on blanket. Dr Gibbs says he would have been concerned if child C had continued to vomit bile and there was a lot of it. Mr Myers produces the intensive care unit chart for June 12, showing, quote, vomit dark bile at midnight. He asked if it is a matter for concern. Dr Gibbs says there is one note of vomit and says that is a worry but would be more concerning if it was repeated. The intensive care unit for June 13th is presented, showing more dark bile readings. Dr Gibbs says there are no more vomit readings and the June 13th readings are from aspirates, which can be common in premature babies. Dr Gibbs says the aspirates were not increasing from 0.5 ml on June 13th. He said the baby would be examined first with an examination of the abdomen. Mr Myers asks if there was a possibility of something other than NEC that child C could have had. Dr Gibbs says that NEC was a particular risk, but there could have been an obstruction in the body, and medical staff would not have just been focusing on looking for symptoms of NEC. A diagram of the small and large intestine is presented to the court. Mr Myers asks about the passage of air and refers to radiograph images for child C, one taken on June 12th, and the accompanying notes refer to, quote, marked gaseous distension of the stomach and proximal small bowel. Dr Gibbs says there is, quote, not much air in the large intestine shown. Mr Myers asks if there is an obstruction. Dr Gibbs says it is a possibility, and the air seen is common for babies on CPAP ventilation. Mr Myers asks if there is an intestinal blockage. Dr Gibbs says it is a possibility. Mr Myers says a symptom of intestinal blockage is vomiting dark bile. Dr Gibbs says there is only one recorded instance of that, and the symptom would be repeated vomiting. He says a sign of an intestinal blockage would be a very distended abdomen, and when he examined him on June 13th, child C had a soft, not distended abdomen. Dr Gibbs adds the amount of dark bile aspirates in the case of an intestinal blockage would increase, and that was not the case with child C. Dr Gibbs says an obstruction is a possibility, but not the explanation. Mr Myers asked if not looking to see whether child C had a potential obstruction in view of vomiting dark bile was a potential mistake. Dr Gibbs repeats there was not repeated vomiting, and dark bile aspirates would be found in normal babies. The court hears child C did not have his bowels open during his life. Dr Gibbs says that was not surprising as he had not been fed. Mr Myers asks if that was unusual after 3 days for the bowels not to be open. Dr Gibbs said it could be unusual, but child C had not been fed, so there were not going to be bowel motions. Mr Myers asks if it would have been preferable for child C to have been examined by a senior consultant prior to June 13th. Dr Gibbs replies it would have been preferable if there had been significant concerns about him and he had not already been reviewed by the registrar and junior doctor. Dr Gibbs said he would have carried out daily reviews without a full examination of neonatal unit babies. Mr Myers asks about child C's collapse. He says Dr Gibbs intubated child C at the first attempt and said Dr Gibbs had told the court intubation was more effective than neopuff. Dr. Gibbs said it was more effective during prolonged resuscitation attempts, and Neopuff by itself was effective too. Dr. Gibbs said even if he was unable to intubate Child C, Neopuff administration could have continued. Mr. Myers asks about the debriefing notes written by Dr. Gibbs on July 2nd, 2015. He says no mention is made about the dark bile aspirates. Dr. Gibbs says that is correct. Mr. Myers asks, was it a consideration on the notes so they could later be seen as part of a legal action, and would that be something that Dr. Gibbs would be aware of? Dr. Gibbs said the purpose of the debriefings was for the benefit of future patients, not for lawyers. Philip Asprey for the prosecution asks about hours worked by Countess staff. Dr. Gibbs said the long hours worked were a widespread problem in the paediatric network, but the quality of care for patients was not diminished. He added, quote, "It would be better for a consultant to be available every day to carry out comprehensive reviews." He said that was the case in most units in the UK. Asked about the dark bile aspirates and the one case of vomiting, Dr. Gibbs said that Child C was not a cause for concern, as the abdomen was soft and the other observations were normal. The prosecution is now reading out agreed evidence statements. The first is from Andrew Brunton, a specialist trainee in paediatrics at the Countess of Chester Hospital at the time of June 2015. He discussed Child C's clinical situation at birth with a consultant who was happy for Child C to be treated at the Countess of Chester Hospital, but that situation would be kept under review. He noted inserting a UVC into Child C, he was not on duty at the time of Child C's collapse. An agreed evidence statement from Nurse Bernadette Butterworth is read out. She recalls seeing the UVC had come out of Child C, which was not a usual sight, and his blanket was wet. She was designated nurse for Child C for the night shifts of June 10th to 11th and June 11th to 12th. On the first shift, she recalled recording readings which included rapid breathing and the incubator temperature was reduced. Child C was, quote, unsettled at times, and oxygen of up to 37% was required to maintain saturation levels. A further note was made to say the UVC continued to ooze. The note concludes, quote, "Will discuss increasing feeds due to large urine output, continue to observe oozing." The nurse said she noted Child C was unsettled and poorly at that time, and on antibiotics. Child C was the same at the end of the shift as he had been when the nurse began the shift at 1 a.m. The nurse's notes from the following night are presented to the court. Child C required varying oxygen support and continued to breathe at an increased respiratory rate. The UVC was found at one point to be out and damp, so had not been out for long. She noted the abdomen appeared distended, soft to firm, not hard. Bowels not open, minimal aspirates. Child C was, quote, unsettled at times and required increased oxygen support after handling. The nurse says for the abdomen readings they were distended but soft to firm, and nurses always check for symptoms of NEC. The distended abdomen can be a sign of the consequences of using CPAP belly. The nurse said from her notes on her night shifts, Child C had minimal clear aspirates. Dr. Evans, independent medical expert, has now returned to court to give evidence in relation to Child C. Nicholas Johnson KC for the prosecution asked Dr. Evans to confirm he has made a number of reports for Child C made between 2017 and September 2022. Dr. Evans confirms that is the case. Dr. Evans confirms he was sent records from Alderhay and the Countess of Chester hospitals, including images and records taken after Child C had died. Dr. Evans says Child C was a vulnerable preterm baby with restricted growth, meaning he was 800 grams at birth. Quote, "He had two significant risk factors. That meant admission to a neonatal unit with careful management that would have been required of several weeks." He said Child C would have been at risk of a number of conditions during that time. The commonest risk would have been to his respiratory system. The second would have related to feeding, as premature babies are not necessarily adapted to receive milk. He would also have been at risk of NEC. The third would have related to infection. The fourth complication would have been metabolic, and it was important to maintain glucose levels and be aware of the risk of jaundice. In relation to the breathing problems, Dr. Evans says from the records, child C's breathing stabilised over the days with CPAP and oxygen support decreasing. Child C had been taken off CPAP and placed on Optiflow, which was a quote, very encouraging sign that child C could begin breathing on his own. The percentage of oxygen support had decreased from a common support of 40% to 25%, the latter which was very low for breathing support. Quote, they were good markers of progress, Dr. Evans said. Mr. Johnson, on behalf of the prosecution, says child C also had periods of skin-to-skin contact with his mum without breathing support required. Dr. Evans said, you wouldn't dream of doing that if child C was unstable on breathing support. Dr. Evans continues to discuss the realistic risks child C could have faced. One was feeding. Dr. Evans says all premature babies require nasogastric feeding. If the babies cannot tolerate that, then it is clinical practice to administer nutrition via TPNs via an IV. Child C was fed via the latter method, which was the right thing to do. Dr. Evans said aspirates would be taken from the stomach prior to feeding. He said dark bile aspirates could be a symptom of NEC or an obstruction, but it would need to be taken in context with other signs, such as the baby's abdomen condition and the general condition of the baby. Signs of a problem would be whether the heart rate would increase, the breathing rate would increase, and or whether the oxygen would need to be increased. Dr. Evans said medical staff were aware to monitor child C's abdomen and make regular notes. He says there is one entry made in the nursing notes of quote black fluid, not necessarily bile but discoloured blood. That was to be monitored and to keep an eye on the baby's condition. It would not in itself be a concern. For the quote one-off vomit reading, Dr. Evans says if there was something serious going on, it would happen more often than once. The 4 dark bile aspirate readings, each 0.5ml, are quote a tiny amount, Dr. Evans tells the court. The good news is it's only 0.5ml. The other good news is the bile aspirate is not increasing per reading. That is an indication the baby is not getting worse. He said increasing readings would point to an obstruction as would a distended abdomen. Dr. Evans said child C's status was quote under control. Dr. Evans says child C was well for a 30-weeker in terms of gestational age. A blood test for CRP had increased from 1 to 22 to 23, quote, not particularly high. The clinical was aware of this and child C was placed on antibiotics. Child C's platelet count had fallen, which on their own don't tell you very much, but in combination with an X-ray was a non-specific marker pointing to an infection. Blood gas readings taken were quote within acceptable values, Dr. Evans tells the court, and in terms of metabolic readings, child C was a stable little baby. Dr. Evans said all premature babies develop symptoms of jaundice. The good news with child C is the jaundice levels were very satisfactory. If child C had signs of severe jaundice, he would have required phototherapy, Dr. Evans explains. Dr. Evans says child C had a lung infection of pneumonia, which was, quote, very common in premature babies, and he was placed on antibiotics in advance of any test results. Mr. Johnson asks, did breathing issues have any direct cause for child C's death? Dr. Evans replies, no. Mr. Johnson asks, did any feeding issues cause his collapse? Dr. Evans replies, no, that cannot explain his collapse either. Mr. Johnson asks, did the infection of pneumonia cause it? Dr. Evans replies, no, the infection was under control and being treated. Dr. Evans explains if the pneumonia treatment was not working, a number of markers would be shown. There would be an increase in heart rate, which did not occur, he says, an increase in respiratory rate, but that stayed the same. Oxygen saturation levels stayed absolutely where they should be, whereas in worsening pneumonia conditions, those levels would fall. Mr. Johnson asks, did jaundice glucose issues cause his collapse? Dr. Evans replied, none at all. Dr. Evans says there were, quote, no worrying trends recorded in the notes. What was the cause of child C's catastrophic collapse and death? Dr. Evans says initially he did not have a conclusion to child C's death. He adds one complication is if the abdomen is filled with air. Dr. Evans said, if you get a significant injection of air into the stomach, it can cause splintering of the diaphragm. As a result, a baby could collapse pretty quickly as they would suffocate. Dr. Evans says that was his conclusion for child C. Dr. Evans says if the diaphragm is unable to move effectively, the lungs are unable to get fresh oxygen and that causes the collapse. Mr. Myers says Dr. Evans has had the case material for child C for about 4.5 years and has provided such conclusions. Quote, "Before today, you have never suggested that the collapse on June 13th, the splintering of the diaphragm, is the cause of death, have you?" That is correct. Mr. Myers suggests that Dr. Evans' opinion alone would not have reached this conclusion. Dr. Evans said the death could not be explained from the usual causes babies get. He said, taking into account all of the other evidence and information from experienced medical people's reports and reading the pathology report, the splintering of the diaphragm was now his conclusion. He said he was functioning as a clinician, quote, "The fact is this baby has collapsed having previously been stable and one has to explain that." Mr. Myers suggests Dr. Evans had been influenced into supporting this conclusion. He says Dr. Evans had not provided this, quote, "splintering of the diaphragm" conclusion in his 8 previous reports. Dr. Evans says while child C was at constant risk of a number of conditions, he was under continual observation and was in a neonatal unit. He confirms his initial conclusion from 2017 was, quote, "One may never identify the cause of his collapse." Mr. Myers said Dr. Evans, quote, "could not rule out infection in his 2017 conclusion." Dr. Evans said infection was a factor in child C's short life. Quote, "It is possible to suggest that his pneumonia was under control. He was requiring hardly any oxygen, and it was my role investigating this unexpected collapse to give an impartial view of all the issues. I don't prepare partisan reports." He says infection was a part of child C's status. He adds it did not cause child C's death. Dr. Evans tells the court the process in accumulating information in reaching his conclusions. He says while child C had an infection, he was recovering from it, as he had gone off CPAP support onto Optiflow. Quote, "Respiratory-wise, he didn't stay the same. He was improving." Mr. Myers says up until the evidence of today, he had not provided in his reports an allegation of harm. Mr. Myers said, "You are coming up with things to support an allegation of harm." Dr. Evans replied, "I'm coming up with clinical evidence." Dr. Evans says he has read varying reports, but had not read a single medical report that said, "I'm wrong, child C died of something else." Dr. Evans says this case, quote, "will always be a challenging case for any clinician, as it's difficult to separate the pathological problems from an event where child C was placed in harm's way by some kind of deliberate act." Dr. Evans said, "You can't exclude infection from child C's general status. He's got an infection, but it's under control." Mr. Myers refers to another of Dr. Evans' reports from 2019, referring to infection being probable as a significant cause in child C's collapse. Dr. Evans says if he receives additional evidence, then he will change his mind. Mr. Myers says Dr. Evans has not received any new evidence on child C's infection since. Mr. Myers says the 2019 report said Dr. Evans raised the possibility of deliberate injection of air from June 12 via the nasogastric tube. Dr. Evans, reflecting on that report, said, quote, "Can't rule it out." Mr. Myers refers to a, quote, "massive gastric dilation was most likely due to an injection of air on June 12. Dr. Evans replies, "That was a possibility, yes." Mr. Myers says in that report there was no suggestion a diaphragm had been splintered since, and if he wanted to say so in that report, he could have done so. Dr. Evans replied, "If it wasn't said, it wasn't said." Dr. Evans said what was being discussed on June 12th, there was, quote, "a distinct possibility child C had excess air in the stomach from CPAP belly. He was, quote, "still stable from a respiratory point of view." He tells the court, quote, "However the air went in, it would have been insufficient to splinter the diaphragm on the 12th, as he would have collapsed and died on the 12th. The air which had gone in was insufficient to cause a collapse. There was nothing to suggest the excess air was enough on June 12th. He says the two events on June 12th and 13th are quite different in the way they happened. Mr. Myers said it was Dr. Evans' view a couple of months ago there was deliberate harm on June 12th. He replied, "That was a possibility. Yes, it was." Mr. Myers asks, "What you have done today in your evidence is introduce something supporting the allegation." Dr. Evans replied, "That is incorrect." He adds that in coming to his conclusions for this case, he is not relying solely on his opinions, but taking in other clinical evidence and reports. That is what doctors do. We do it all the time, in what Dr. Evans says is a, quote, complicated case. Mr. Myers has gone back to the case of child B to discuss the legibility of a nursing note concerning blotchiness of child B's skin. The discussion goes on for several minutes. Dr. Evans adds, "This is just making a meal out of something." Mr. Myers replies, "You're not independent as a witness, are you, Dr. Evans?" Dr. Evans replies, "I am completely independent. I am not here for the prosecution. I am not here for the defence. I am here to assist the jury." The judge interjects to clarify the meaning of the note before the case resumes on child C. Mr. Myers asks about the bile aspirates and asks if the dark colour was additional concern. Dr. Evans says it could be discoloured blood and the presence of vomit once would be a concern, but would need to be put in context of the baby's condition. Quote, "You can't choose out something that supports your case. You need to look at the big picture." Mr. Myers says the X-ray from June 12 had helped form Dr. Evans' initial view that there had been an air injection into the stomach. Quote, "That was an opinion I have expressed, yes." Mr. Myers asked Dr. Evans what evidence there is to support that air had been injected into the stomach on June 13th. Dr. Evans replied, "The baby collapsed and died." Asked to explain further, Dr. Evans says it was part of a differential diagnosis. He said there were 3 clinical scenarios: injecting air into the stomach that interfered with his breathing, or that air was injected intravenously, or from a combination of the two, which Dr. Evans says, quote, "sounds awful." Dr. Evans says from his perspective, from an academic point of view, he would not be able to rule out any one of those 3 scenarios. Dr. Evans says none of the normal processes described why a baby collapsed. He adds for further medical information, he would prefer to defer the matter to the radiologist and pathologist. He said he objects to being accused by Mr. Myers of making things up, and says he is putting forward the information in this case as a result of his own opinion and that of other people's reports. Mr. Myers says, quote, "Never once is an air embolus mentioned in Dr. Evans' reports." Dr. Evans agrees. Mr. Myers suggests that Dr. Evans has just made up information as he has gone along. "You keep saying that, and I keep disagreeing. And you're not an independent witness at all, are you?" And again, that is just being insulting. Independent medical expert Dr. Sandy Bowen has returned to court to give evidence this time for child C. Dr. Bowen confirms, after being asked by Mr. Johnson, she has received and reviewed all the case evidence, including from doctors' witness statements. Dr. Bowen says her role was not to rubber stamp anything, but to come up with her own conclusions and see whether they agreed with that of Dr. Evans. She said she set out what she thought were the important facts for child C. They include an X-ray taken on June 12 following the insertion of a long line. She noted the long line was in a, quote, "low position but in a usable position." The stomach looked swollen and had a distended bowel. She said initially she could not see a nasogastric tube on the X-ray image on her laptop, but from viewing the X-ray image shown in court in higher resolution, she could detect it was present, quote, "very high in not an ideal position." Dr. Bowen is asked about her conclusions regarding child C. She said it was known child C was premature, growth restricted at birth, and potentially at risk of complications, but managed very well indeed in his early days, improving to being put on Optiflow. He had clearly not liked being on CPAP and had been put on skin-to-skin contact with his parents without CPAP for a couple of hours and had done well during those times. Quote, "This was not a baby who was ill. This was a baby who was improving." Dr. Bowen noted child C, quote, "clearly had an infection which was an alerting feature, and for which the medical team treated him with antibiotics and did an X-ray confirming left lung pneumonia. Despite that, child C had appeared to respond to treatment due to the lessening of respiratory support." Dr. Bowen said it was, quote, "very clear child C had pneumonia, but a baby with pneumonia will often survive. But a sign of that will be that they would slowly deteriorate, going from CPAP to ventilator support, increased heart rate and breathing rate. Child C's breathing rate was very stable, despite effectively breathing with one lung. Dr. Bowen's conclusion was that he had pneumonia, but that did not cause the collapse or kill him. Dr. Bowen said pneumonia would be a factor in the difficulties in response to resuscitation. She tells the court there would be a sign something was amiss prior to the collapse, and a sudden unexpected collapse would be uncommon in babies. Dr. Bowen says babies on CPAP can have CPAP belly, and in order to minimise that, they would aspirate the NGT. Quote, "It is usual practice to note down the volumes of air aspirated to give colleagues an idea of how much air is coming out of the baby. I couldn't find any evidence of that in the notes." She adds that, for babies not fed, the nursing staff would put the tube on free drainage so air could come out on its own, as well as actively aspirate every 4 hours or so. She says there was only fleeting mention of free drainage. If neither of those things happened, Dr. Bowen said, that would lead to gas accumulation in the stomach. Dr. Bowen said it was not clear from the notes how long the free drainage was in place. She said one conclusion for child C's collapse was CPAP accumulation of air, the other being deliberate injection of air. She said the doctors did not appear to have a concern as they had noted the abdomen to be soft. Dr. Bowen said child C died with his pneumonia, not because of his pneumonia. She added babies such as child C do not collapse suddenly and without warning. She said an infection would not be the cause, as that would lead to a gradual deterioration in the baby, not a sudden collapse and no response to resuscitation. In the past week, members of the jury have been hearing evidence in relation to the fatal collapse of child C at a neonatal unit in the Countess of Chester Hospital. It is expected that today the case will turn to the fatal collapse of child D in June 2015. The prosecution say that Lucy Letby, as in the case of child A, B and C, administered a fatal air injection. The defence deny this. During the prosecution opening statement, the jury has heard child D, a baby girl, died following 3 collapses in the early hours of June 22, 2015. As has been the case for the other children in the case so far, the court will hear evidence of the circumstances which happened in the days leading up to child D's collapse. As ever, the case is being heard in Manchester Crown Court in front of a jury of 8 women and 4 men, and the trial is expected to last 6 months. This is the 4th week of the trial being heard before a jury. Child D's mother is now being called to give evidence. A reminder that the family members of any children involved in the case cannot be identified due to reporting restrictions. The prosecution, led by Nicholas Johnson KC, asks Child D's mother to confirm details. Child D's mother tells the court she developed a concern about her waters breaking, which the court hears was, quote, well-founded as her waters broke when she woke up on June 18th. The hospital told her to, quote, monitor the situation. She waited and rang the hospital again and was then told to go to hospital. At 11:30 a.m, she arrived at hospital and staff confirmed her waters had broken but did not test. They then checked her and her baby, quote, not for very long. Were you, in effect, sent home after being examined? She replied, yes. The following day, the mother returned to the hospital and saw a midwife. Were you examined and various checks performed on you? She replied, yes, not straight away. I had to wait. Did you express concern to the staff at the Countess? The mum said her waters had broken over 24 hours before. She didn't, quote, feel right, and the baby didn't seem to move as well. And she was concerned about infection as she hadn't been given any antibiotics. The decision was then taken to induce. She said staff were, quote, very busy, and she was placed on an IV, but not for, quote, many hours. It was, quote, very delayed, the mother tells the court. The mother said she was very worried and scared, unwell and not in control, and forgotten by the staff, as it was nearly 48 hours after her waters had broken. On a trip to the bathroom, she noted blood had come out. She asked someone to do something. She said she remembered seeing a doctor and recalled giving a description of her. It was the first time she had seen a doctor since her admission. She was told that essentially both her and her baby girl were okay, and that a natural birth would be considered, and that it would be reviewed 4 hours later at 11 a.m. At 11 a.m, the mother was assessed again by a different doctor. She was told there had been little progress, and she said he was the first professional who spoke to me and addressed my concerns. The mother said it had been about 50 hours since the waters had broken, and a C-section was considered as there had been no dilation. The mother was informed a natural birth would be the preferred option to a C-section. By 3 p.m, the mother had discussed the situation with her husband and concluded she would be, quote, less patient and call for a C-section if there had been no progress. At 3 p.m, the mother was reviewed by the same male doctor, and he was, quote, more concerned about the situation as she appeared more tense. The doctor then confirmed she would receive a C-section as he said it was, quote, not a good idea to wait any longer as the baby appeared distressed. Events then moved on, quote, a lot more quickly after staff had initially appeared chilled. After the C-section decision was made, matters moved a lot more quickly. Child D was delivered and lifted over the screen for the mother to see. The mother recalls seeing, quote, no life, lifeless, she did not scream, everything was quiet in the room. Mr. Johnson asks if there was a nurse in the theatre room at this stage. The mother does not recall. The mother was taken to a ward while medical professionals dealt with Child D. The mother recalls seeing Child D very briefly in the operating theatre before they, the staff, took her away as they had concerns. The mother said she was, quote, very aware of things going on, despite having received anaesthetic. She did not have physical contact with Child D, but her husband did. The mother was taken to a ward. The mother was taken to a further room, and it was there where she had physical contact with Child D. Her impression of Child D's condition at that point was, quote, really worried as she was brought to my chest, but she didn't have any movement. She looked limp and pale, struggled to breathe and was making a groaning noise. She wasn't really responsive. There was a split second where she opened her eyes and looked at me, but then no response. I tried to breastfeed her, but she was completely limp, so I was worried. A male paediatrician informed the mother, quote, not to worry, as the delivery had been through C-section so the breathing wasn't as clear. The mother said she didn't believe what he said. His attitude seemed, quote, too careless. The mother said she thought something was wrong with Child D and one of the midwives would assess her in a couple of hours. She said she did not want to wait that long and wanted another doctor's opinion. The same doctor came back, but he had spoken to a consultant. The mother said she was, quote, not reassured, but was glad someone took me more seriously. She was then worried as Child D was taken straight to neonatal unit intensive care. The mother said she felt, quote, rubbish, drained, and didn't feel any relief. She was in pain and knackered. The mother said it was around 7 to 8 p.m. when she was separated from Child D. The following day was Father's Day. The mother was given the news that Child D had been, quote, up and down all night, struggling with feeding, and staff didn't seem too concerned then, but Child D wasn't great. The mother believed she had been spoken to by a female consultant doctor that morning. The mother said she recalled Child D needed to be on a CPAP machine, and every time they tried to take her off, she would crash. She said staff did not seem overly concerned as Child D was a good-sized baby and making progress, despite being, quote, poorly. Other tests showed she seemed fine. The mother said she was able to see Child D at about 7 p.m. that day. The mother said she had spoken to a doctor before heading to the neonatal unit. A drawing that the mother had made showing a plan of the neonatal unit room is shown to the court, showing the positioning of Child D's cot, other cots and crosses identifying a number of medical machinery. Child D's mother said she had spoken to Dr. Andrew Brunton at 9 to 9:30 p.m. and was told he was, quote, very happy with Child D's test results. They had done more scans and she was well, and promised her she would be able to hold and cuddle her the following day. The mother said she was not in a good condition herself, being moved in a wheelchair and 10 out of 10 in pain, but was happy with Child D. Child D looked like, quote, a good pink baby, tiny but chubby and looked healthy. The next time she saw Dr. Brunton was the following night. She and her husband were woken up at about 4 a.m. by a nurse to come quickly as Child D was poorly. They rushed downstairs and Dr. Brunton was holding her and trying really hard to resuscitate her. We were just standing there looking at Child D dying. The doctor was, quote, quite agitated and the couple heard they had to let Child D go. The mother said she could not stay there anymore and asked to be taken away. A nurse, who the mother believed to be Lucy Letby, was holding a phone to Dr. Brunton's ear, she recalled. The mother said she had seen Lucy Letby before when she went to see Child D in a neonatal unit at around 7 p.m. The mother recalls as she was wheeled into the room, Lucy Letby was, quote, hovering around, not doing much with Child D. She had a clipboard and was looking at the machinery. Quote, I didn't understand what she was doing. And the mother asked if Child D was fine, to which Lucy Letby said she was. Lucy Letby, quote, just stuck around and was just watching, looking over us. The mother said she asked Lucy Letby to, quote, just go away and leave us in privacy. Mr. Johnson asks if Lucy Letby was in the neonatal unit room at the time Child D died. The mother agrees and says other doctors were in that room. The mother says she did not stay in that room. The mother recalls she was taken to a private room where Child D was, along with her husband and another family member, and a nurse she had not seen before. The mother said she did not see Lucy Letby again. Ben Myers, KC for the defence, is now asking the mother questions. Mr. Myers says it is an awful experience what the mother went through, and says he has one or two questions to ask. He asks about the 7 p.m. neonatal unit visit on June 21st. The mother said she went there with her husband. She recalls 7 p.m. as she, quote, must have looked at the clock. She said there was an exchange of few words between her and Lucy Letby. Mr. Myers asks if that was possibly another nurse. The mother replies, quote, I don't think so. The judge, Mr. Justice Goss, asks for clarification. The mother said she would not have known the name of Lucy Letby at the time, but would after seeing her picture after she had been arrested. The court is now hearing an agreed evidence statement from the father of Child D. The court hears from the statement Child D died at 4:25 a.m. on Monday, June the 22nd. He said he does not remember any specific problems from the mother's pregnancy, but had, quote, immediate concerns when she was born as she appeared grey and was not crying. Quote, initially we were reassured by the staff, and he said he believed them and never thought Child D would die in the circumstances she did. The father recalls the circumstances leading up to the birth as recalled by the mother. He recalled the mother did not respond to inducement measures and had mild contractions between 2 and 3 a.m. on June the 20th, but had not dilated. She was, quote, encouraged to wait for inducement methods, but she did not want to as she had been in labour for some time. They were told medical staff were, quote, monitoring the situation and were told antibiotics were not necessary at this stage. They said they agreed on a C-section, and at about 4 p.m, the mother went for an emergency C-section. Child D was held above the sheet momentarily and wrapped up and taken to the scales. Quote, we weren't informed of any issues. I was led to believe everything was okay. He said Child D was very quiet, which was unexpected, and held her in his arms. He said he was not sure if Child D was given any breathing support at this stage. He went back to the ward with Child D for a brief time, and he and the mother put pyjamas on her. However, quote, she didn't seem interested in feeding at all. They said they were told Child D was doing well. Quote, we repeatedly asked if she was okay. We just weren't comfortable with how she was. Medical staff kept telling her Child D was okay. A few hours later, a different paediatrician came and Child D was taken to the neonatal unit. The parents were later told Child D was not well. Quote, it was a bit of a shock when the father saw Child D in a neonatal unit as she was, quote, very poorly, wasn't feeding and had lots of tubes in her mouth. Nursing staff, quote, always made the father feel welcome when he arrived. On June 21st, the father went to see Child D and was, quote, almost certain he saw she had been taken off CPAP. He said he frequently visited the neonatal unit and asked staff. Quote, it was Father's Day and I was given a handmade Father's Day card. The staff had put it together and it had a message from Child D with a photo stuck inside. On the first photo, she has CPAP. I took that with me. Quote, later that day I was given a welcome card and a photo which showed her looking better and not on CPAP. In the early hours of June 22nd, he was woken by a nurse to go to the neonatal unit as Child D was poorly and they were taken there quickly. Quote, when we walked in, we understood immediately it was very serious. Andrew, the senior doctor, seemed to be in charge. I remember someone mentioning adrenaline and there was a sense of urgency. Andrew had a phone held up to him and he was discussing the situation with someone on the other end. There seemed to be some confusion over what baby they were talking about. The person on the other end seemed to be referring to a different baby. They were unsuccessful in resuscitating child D. They said they'd been trying to resuscitate child D for over 20 minutes. I couldn't tell you which staff were in, as I wasn't paying much attention. I didn't want to look. He added the parents weren't in the room for too long, about 5 minutes. He does not recall seeing Lucy Letby at this time. He went back to the ward and informed another family member of the news. Intelligence analyst Kate Tyndall has returned to give evidence and give a walkthrough to the jury on the evidence tiles in the electronic bundle. The first evidence shown to the court is Lucy Letby's shift patterns for June 2015. It shows which days Letby was on, quote, long day shifts and night shifts. She worked long day shifts on June 2nd, 4th, 17th, 19th, 27th and 28th. She worked night shifts on June 8th, 9th, 13th, 14th, 21st, 22nd and 23rd. Child A died on the night of June 8th, 9th, and Child B had a non-fatal collapse on June 9th, 10th. Child C died on the night of June 13th, 14th. Child D died on the night of June 21st, 22nd. The evidence shown to the court shows Child D was born at 4:01 p.m. on June 20th, weighing 3.13 kilograms, 6 pounds 14 ounces, and required breathing support at birth. The APGAR scores were 8 out of 10 at 1 minute after birth and 9 at 5 minutes. Child D was admitted to the neonatal unit at 7:30 p.m. on June 20th, quote, for respiratory support requiring ventilation. Child D was, quote, grunting and her colour was dusky, it was observed. Child D was placed on CPAP with 40% oxygen support and placed on double phototherapy. Dr. Ahmed Chowdhury noted discussing Child D with the parents, saying, quote, on moving baby to labour ward, baby become blue, dusky. SATs 47% on arrival NNU. Had bagging, SATs picked up, given antibiotics, baby put on CPAP, not explained to parents yet. Notes record the administration of antibiotics and sodium chloride to Child D. The court hears phototherapy was carried out to treat Child D's jaundice. Child D was administered with an endotracheal tube on the second attempt. The nursing notes record Child D was, quote, starting to put a few breaths in for herself now. An X-ray reading for Child D showed shadowing consistent with transient tachypnea of the newborn, TTN, a respiratory disorder. A nurse's note recorded meeting the father who had visited the neonatal unit, and it was explained to him that Child D would be on the neonatal unit for, quote, at least 48 hours, and the dad was visibly upset, so lots of reassurance was given to him. A further nursing note at 4:30 a.m. on June 21st showed Child D was making, quote, good respiratory effort and blood gas readings were good, so ventilation support was reduced. Another nursing note at 7:21 a.m. recalls the father's visit to the neonatal unit. It includes, quote, father appeared overwhelmed, so lots of reassurance given. A note from nurse Kate Bissell reads at 9 a.m. on June 21st that Child D was, quote, extubated following satisfactory blood gas. Child D was initially apneic and required stimulation via neopuff CPAP, but the breathing became more regular after a couple of minutes. Kate Bissell, in a subsequent nursing note, said a blood gas reading at 10:15 a.m. was subsequently taken and the results showed signs of respiratory acidosis, so Child D was put back on CPAP. The blood gas was repeated 2 hours later and showed further deterioration with increasing metabolic acidosis. Child D's perfusion was, quote, poor, and a doctor approved a decision to administer medication. Dr. Ahmed Chowdhury recorded a UVC and a UAC were inserted. The court is continuing to go through the sequence of events, which is up to the afternoon of Sunday, June 21st, 2015. A family communication note is made at 5:53 p.m. Quote, dad visiting most of the day, he is up to date with the plan of care, mum has visited this evening. Both parents were anxious about the levels of care provided. A nursing note at 7:15 p.m. said attempts were made to get Child D off CPAP, but breathing was still shallow off that, so CPAP resumed. Swipe data showed Lucy Letby arrived at the neonatal unit at 7:26 p.m. The handover note showed Letby was one of the nurses on duty that night, with a different nurse being the designated nurse for child D in room 1. Letby was a designated nurse for 2 other babies in room 1. At this time, another nurse was looking after child B in room 3 for that night. The court had previously heard child B had suffered a non-fatal collapse earlier that month. Further observations for child D are documented throughout that night shift until after 1 a.m. A neonatal infusion prescription chart at 1:25 a.m. for child D is shown to the court. Lucy Letby is one of the 2 nurses to provide a signature for a saline dose prescription at that time. Child D then first collapsed at 1:30 a.m. Mr. Johnson for the prosecution asks, "This is within a very short time of the document with Lucy Letby's signature on, isn't it?" Kate Tyndall replies, "Yes." A nursing note, timestamped for 1:30 a.m. but written retrospectively, recalls, quote, "Called to nursery ward, child D had desaturated to 70s, required oral suction as was bubbly and had lost colour. Discolorations to skin observed, trunk, legs, arm, chin." Notes of medication are made. At 2:40 a.m, a neonatal infusion prescription chart is recorded for a sodium chloride dose with 10% dextrose. Letby is one of the 2 nurses signing for it. The medication administration update is made on the computer at 2:44 a.m. At 3 a.m, child D collapsed for the second time. The nursing note recorded for 3 a.m, quote, "Child D crying and desaturated again to 70s, commenced on 100% O2 via CPAP and picked up well, but skin discoloured again." At 3:20 a.m, a further neonatal infusion prescription is made, with Lucy Letby being one of the signatories. At 3:45 a.m, child D collapses for the 3rd and final time. The nursing note recalled the alarm went off and child D, quote, "desaturated and then became apneic. Called Letby. Resuscitation efforts began, but to no effect. A bleep alarm went off and doctors were called to the neonatal unit." The court is shown a number of clinical notes are made by doctors for this time. These clinical notes will be discussed further when the doctors involved in them come to court to give evidence in the coming days. They include the resuscitation efforts, administration of adrenaline doses, and the decision ultimately to discontinue CPR. Child D died at 4:25 a.m. A text message sent from Lucy Letby to a colleague said at 8:36 a.m, quote, "We had such a rubbish night. Our job is just far too sad sometimes." The colleague replied, "No, what happened?" Letby, "We lost child D." The colleague replied, "What? But she was improving. What happened? Want to chat? I can't believe you are on again. You are having such a tough time." Letby refers to child D being, quote, "messed about a couple of times," and refers to a rash that, quote, "looked like overwhelming sepsis." She adds that 2 members of staff said the circumstances, quote, "would be investigated." The colleague replies, quote, "Dad was very anxious all day," and adds in relation to the investigation, "What's the delay in treatment?" Letby replies, "Just overall looking into the case and reviewing what antibiotics she was on if sepsis." The colleague says child D, quote, "was behaving septic." She adds to Letby, "Oh hun, you need a break." Letby said in her response, quote, "But it's part of the job and it's hard for everyone." The colleague responds, "Yes, but you have had it all recently." Letby in her response says, well it's happened and that is it. Got to carry on," before referring to her planned time off. The conversation then discusses staffing arrangements and the difficulties of the job before noting an instance of a happier occasion on the unit. Letby says, quote, "How do such sick babies get through and others get to die so unexpectedly?" Her colleague in her response says, "We just don't have magic wands." The colleague refers to what child D looked like in their care. Letby replies, quote, "I think there is an element of fate involved. There is a reason for everything." The colleague adds, quote, "It's important to remember that a death is not a failure," and says Letby is an excellent nurse. Letby in her response accepts the need to take positives from the job, but it's, quote, "just so sad to watch what families go through." Further messages are exchanged between Letby and her colleague the following evening. The colleague asks, "How are you doing?" Letby replies, "I'm okay, try not to think about it. Work busy, but at least we have 6 tonight. The colleague inquires about child D and whether anything had been said about not, quote, bringing her through sooner on Saturday. Letby replies, I don't think so, before adding there was a theory child D may have had meningitis. The colleague responds, quote, I'm worried I missed something. Letby responds, I don't think any of us did, and she, child D, was on the right antibiotics. The colleague replies, yeah, just would treatment sooner have made a difference? Letby asks her colleague if child D had a lumbar puncture. The colleague replies she was not sure it ever got done, given that the baby girl was ill and had been on CPAP. She adds her gas reading was, quote, appalling when she first came through to the unit. Letby in her response says, I think we did what we could. She then refers to the condition of the mother of child D. The court hears at 9:51 p.m. on June 25th, Letby search for both the parents' names of child D on Facebook. Towards the end of June, Letby sent a message to a colleague, quote, work has been awful. The colleague responds, oh dear, staffing probe? Letby in her response says, we have had 3 unexpected deaths, adding the unit is full. She adds, quote, what I have seen has really hit me tonight. The colleague asks, have you worked today? Letby replies, no, been off since Wednesday morning and now it has all hit me. The colleague asks if Letby tries talking to a proper counsellor. Letby replies that she does not think she can. The colleague responds, why not? Letby replies, I can't talk about it now. I can't stop crying. I just need to get it out of my system. The colleague advises Letby to think carefully what to do before adding, quote, maybe you need to take time off. Letby replied, work is always my priority, adding she had not cried about the incidents until then. Caroline Oakley is now being called to give evidence. In June 2015, she was employed as a senior neonatal unit nurse at the Countess of Chester Hospital. Mrs. Oakley confirmed she would at times be a shift leader and would look after the people on that shift, not necessarily working with managers. She confirmed she had direct involvement with child D on the night shift from June 21st to 22nd and was her designated nurse during that shift. Mrs. Oakley says she does not recall which nurses were designated nurses for which babies that night. Her nursing note, written retrospectively at 4:46 a.m. on June the 22nd for the night shift, is presented to the court. The note records at the handover, quote, lower limbs dusky and feet bruised, doctors aware. Feet cool to slightly warm, observation satisfactory. Mrs. Oakley added child D was, quote, nursed on CPAP in air, antibiotics given as prescribed. Mrs. Oakley tells the court child D was not pink yet and might have been sampled with heel pricks which could make the feet bruised. She said it was something to monitor but was not a concern at that stage, and those observations had been relayed to doctors. The nurse said child D's circulation was not 100% brilliant at that point, but this was common in newborn babies. The note records child D was reviewed by Dr. Andrew Brunton. The decision was made to, quote, commence feeds and increase as tolerated with expressed breast milk. Blood gas readings taken at 11:52 p.m. and 1:14 a.m. were, quote, satisfactory. Mrs. Oakley said she remembered, quote, being very happy with her at that point of the night shift. While child D was an intensive care patient in the neonatal unit, she was only requiring a little assistance with breathing and she was stable. The observation chart for child D for that night shift is shown to the court, which shows Caroline Oakley's initials signing hourly observation readings. The heart rate, respiration rate and temperature are recorded. Child D's heart rate says for the first few hours the heart rate was, quote, completely normal up to 12:30 a.m. It had peaked at 1:15 a.m, but could have been after handling and or a nappy change, Mrs. Oakley tells the court. She said that reading was, quote, still within normal parameters. The respiration rate was at the, quote, upper end of what would be considered ideal, but was still within normal parameters, Mrs. Oakley adds. The temperature readings are also, quote, completely normal with no high temperature. A further observation chart records the readings made for child D being on CPAP. The chart recorded child D did not require oxygen support at this stage having been taken off that in the early hours of June 21st. The oxygen saturation levels were 100, which meant child D was breathing beautifully. Another intensive care chart is shown to the court, showing fluids administered during the evening and night of June 21st. A quote, minimal amount of acidic aspirates is recorded from the stomach in the evening. It was followed by quote, mostly clear aspirates with occasional darker bits. Mrs. Oakley says there was nothing she was worried about from those readings. The neonatal infusion prescription chart at 1:25 a.m. is shown to the court. It is signed by Caroline Oakley and Lucy Letby. Mrs. Oakley says usually the nurse looking after the baby will administer it. She confirms the two signatures made, showing they had checked the fluid. Mrs. Oakley adds, quote, I would presume that I connected the fluid. At 1:30 a.m, Nurse Oakley's notes record, quote, call to nursery by senior nurse and senior nurse Letby. Child D had desaturated to 70s, required oral suction as was bubbly and had lost colour. Discolorations to skin observed. Trunk, legs, arm, chin. Dr. Brunton called to review. Mrs. Oakley says she remembers being on her break at 1 a.m. to 2 a.m, so was in the resuscitation room where staff had their breaks. She said she had gone because child D was poorly. The prosecution asked about the timing of the 1:25 a.m. medication and if the nurse can account for that. Mrs. Oakley says she cannot. She says, quote, to the best of my knowledge, I remember going on my break and remember being called back. I'd only been gone for half an hour and I'd been really happy with her before I left. I remember saying, what's happening? Asked about the note, Mrs. Oakley said the bubbly bit is for bubbly saliva. She says she does not remember specifically the exact rash discoloration, but, quote, hadn't seen it before. It was dark, it was unusual, and the rash struck me. Asked to expand on that, she says, quote, I haven't seen that rash before on a baby I have looked after, to the best of my knowledge in all my years of neonates. Mrs. Oakley adds, quote, it was unusual, I had not seen it before, and probably struggled to describe it. It was a deep red-brown, different from mottling, different from what I'd seen before. She says sometimes babies can look generally white with a mottled all-over appearance, whereas this was a rash in specific places. She says, quote, it was just different from what I'd seen before, that's what stayed with me. The nursing note adds, quote, saturations to 100 and O2 weaned to air, observations satisfactory. Mrs. Oakley said she couldn't recall who was doing what, but the oxygen was turned up on the CPAP machine and child D responded. The note adds, quote, Dr. Newby called in to review, fluids increased, and a number of drugs and solutions were administered and prescribed. The note adds, quote, discolorations resolved, abdominal x-ray taken satisfactory, continue supportive treatment i.e. antibiotics, maintain UVC i.e. don't take it out, decision to speak to parents later as child D stable and doctors required on paediatrics, repeat gas good. Mrs. Oakley confirms the rash-like appearance had, quote, resolved between 1:30 a.m. and after the doctor's review. She says child D had an episode but had responded quickly and normal parameters had resumed within an hour. As child D was very stable again and the doctors were busy, the decision was made to let the parents rest and inform them in the morning. Mrs. Oakley is asked to put into context further observation readings at 2:30 a.m. for child D, which had, quote, returned to normal. She says they would be considered stable. At 1:30 a.m, fluid readings record, quote, nil by mouth at the time for child D, along with, quote, oral secretion ++ for aspirates. The fluids chart also notes what Mrs. Oakley believes is a task carried out for child D by Lucy Letby at 1:05 a.m, which she said would have been noted retrospectively, as Mrs. Oakley would have started her break at this time. Nurse Oakley's nursing notes add, 3 a.m, child D crying and desaturated again to 70s. Commenced on 100% O2 via CPAP and picked up well, but skin discoloured again but less than previously. Dr. Brunton called to review. Take off NCPAP, further fluid bolus and gas. 1-hour cares attended to, passed urine and passed meconium. Mrs. Oakley says she cannot recall the events around this collapse and says her memory of it is limited to that of her notes. A nursing note of drug infusion, which Mrs. Oakley says the doctors believed child D would need more fluid on board, is noted at 3:20 am. The fluid chart records for 3:30 am, quote, "Restart expressed breast milk 1 ml. The prosecution say the collapses had been of concern to nurses and why the doctors were called. Mrs. Oakley said after the review the doctors were, quote, "happy with her and for fluids to continue to be administered." She added child D had passed urine and had a wet nappy, and so she was comfortable in changing her nappy. Quote, "If I thought she was unstable, I would not have chosen to change her nappy. If the baby's unstable, they do not tolerate handling. Even cleaning them could cause them to be unsettled with their heart rate going up." The nurse added, quote, "Observation satisfactory and child D was handling well. The final observation readings were all in normal parameters at 3:30 am. At 3:45 am, the nurse noted, quote, "Monitor alarming. Child D desaturated again and stopped breathing. Called senior nurse Letby to help, stimulation given. Use of Neopuff was given at 3:52 pm. A senior house officer was called to help. Dr. Brunton called to help, resuscitation efforts began." The prosecution asks if Mrs. Oakley has a memory of this. She says she does note it was, quote, "just a blur, just very busy. She misbehaved, had gone poorly again, I don't remember specifically." She does not recall if an alarm went off. From her notes, she called Letby to assist. The initial stimulation effort was, the court hears, to tickle the feet, trunk, ears, which can in itself get a baby stimulated enough to start breathing. Mrs. Oakley says she played a part in the resuscitation efforts. Ben Myers KC for Letby's defence is now asking Caroline Oakley questions. He asks if she was aware of the increased mortality rates between June 2015 and July 2016, and in a police statement said it was, quote, "a busy and stressful time." Mrs. Oakley agrees. He asks whether that was from increased admissions to the neonatal unit. She replied, "There were a lot of babies." She said she couldn't say it was an increase and would have to see the statistics. Asked if there were an increased number of acutely poorly babies, Mrs. Oakley replies, "I'm not sure. I worked there a long time. We used to take a lot of 24-weekers when I started over 20 years prior. I remember midwives bringing babies in when we were busy." She says she does not remember the unit being unduly short-staffed. Mr. Myers suggests that at times of crisis they had the staff they required. Nurse Oakley replied, "Yes, as they would be called from other patients." Mr. Myers replied, "But maybe at other times you didn't have as many staff as you needed." Nurse Oakley replied, "I'm not sure." He refers to child D as an intensive care baby. Mrs. Oakley says she wasn't a poorly intensive care baby as she wasn't on ventilator support. She says child D was, however, classified as an intensive care baby. The chart showing Mrs. Oakley looking after child D in room 1 and a baby in room 2. He says intensive care babies require one-to-one support. She replied, "Ideally, yes." He says the fact Mrs. Oakley was looking after another baby too that night fell outside the guidelines. "That isn't in the guidelines, is it?" Mrs. Oakley replied, "Strictly speaking, no, but it does happen." Mr. Myers asks, "It's important that with babies like child D you remain vigilant as they can deteriorate quite suddenly, can't they?" Mrs. Oakley replied, "They can, yes." Mr. Myers asks if Mrs. Oakley was aware that child D had been on a ventilator until the early hours of June 21st. She says she only knows that from the medical notes. Ben Myers KC for the defence is continuing to ask Nurse Caroline Oakley questions. He asks if she knew there had been a delay in giving child D antibiotics after birth. She says she cannot remember, but can see from the notes. Mr. Myers refers to a nursing note from June 21st during the day that there were signs of respiratory acidosis after extubation. Mrs. Oakley says she cannot remember that note, but she would have been told about it during the shift handover. Mr. Myers refers to the note continuing with, quote, blood gas repeated 2 hours later showed a further deterioration with increasing metabolic acidosis. He asked whether she would have been informed of this. Mrs. Oakley replied, I'm sure it would have been mentioned at the handover, yes. Mr. Myers asks about the attempt to take child D off CPAP at 7:15 p.m, but child D began shallow breathing again so was put back on CPAP. He said, quote, what we have is a baby who has been struggling to breathe unaided throughout the day. Mrs. Oakley replied, yes. Mr. Myers says there are warning signs she was not in an optimal state, an indication she was unwell. Mrs. Oakley replied, if she needs help with her breathing, yes. The observation chart is shown for child D for the night shift again to the court. Mr. Myers then refers, for context, to the previous 24 hours, showing child D's observations were in, quote, the warning zone for heart rate and breathing rate on several hourly observation readings from late on June 20th throughout the day of June 21st. A blood gas readings chart is shown to the court. The pH readings recorded at 10:14 a.m. and 12:10 p.m. on June the 21st of 7.194 and 7.173 are, quote, acidic. Mrs. Oakley agrees. She adds that doctors would have a better idea of the parameters of what would be normal readings for babies. Mr. Myers, referring to other readings, says the situation is not as good at 11:52 p.m. as it was at the reading from 6:44 p.m. Mrs. Oakley agrees. Mr. Myers says the blood gas readings are worse at 1:14 a.m. and point to deterioration. Mrs. Oakley says the readings to her are not as good as earlier, and says the doctors would take action based on them. Mr. Myers refers to the break Mrs. Oakley took between 1 and 2 a.m. Mrs. Oakley says she is not sure the 1:14 a.m. blood gas reading notes are in her handwriting. Mr. Myers refers to the 1:15 a.m. observation chart reading note, which has Mrs. Oakley's signature initials. Mrs. Oakley says she would have usually expected to write those observations at 1:30 a.m. Prior readings are 11:30 p.m. and 12:30 a.m, with subsequent readings at 2:30 a.m. and 3:30 a.m, and may have written them retrospectively. Quote, it does happen. An IV prescription chart with Mrs. Oakley's signature initials at 1:25 a.m. is presented to the court. Mrs. Oakley said the prescription is not in her handwriting. Mr. Myers says it's not unusual for nurses to help each other out, particularly for procedures which could involve two nurses. Mrs. Oakley agrees. A fluids chart is presented showing the gastric tube change recording 0105 suction PP2 AXR bolus. Mrs. Oakley says she believes she has written that retrospectively and has summarised what was told for that 1:05 a.m. She has summarised that they wanted a bolus and an abdominal x-ray. She says she would have been told all this by Lucy Letby, by another nurse Kate Percival Ward, or a combination of both. Mr. Myers refers to the 1:30 a.m. collapse of child D. Mrs. Oakley says it was a short distance from the resuscitation room to room 1 and does not recall who came to get her. Mr. Myers said child D responded well to the oxygen and no resuscitation was required. Mrs. Oakley agrees. Mr. Myers refers to the skin discoloration of child D at the time of the first collapse. Mr. Myers asks, does that suggest the skin discoloration was all over her body? Mrs. Oakley replies, the front of it, yes, but I don't know if it was all the trunk. I don't think it was all the trunk, all the legs. Mr. Myers refers to her finding the rash-like appearance being, quote, unusual and a struggle to describe it. You said you couldn't remember it. It was a deep red-brown. Is that what you saw? I just remember the rash. I don't remember the specifics of it. I just remember it was an unusual rash. Would it be fair to say the fact it was unusual stuck in your mind? It always has, yes. Mr. Myers refers to the 3 a.m. collapse of child D. He suggests that Mrs. Oakley was present at the time of the collapse. Mrs. Oakley says she would have been in the vicinity at the time and does not remember what she was doing. Mr. Myers says it was an episode which resolved quickly and resulted in a decision to take child D off CPAP. He asks whether there had been a discussion about child D's breathing support difficulties earlier that day. Mrs. Oakley says she does not remember. She says she believes if the desaturations had gone to the 70s, the alarms would have gone off and she would have been alerted to child D. The 3:45 AM collapse is now being referred to. Mr. Myers says at that point, child D had been taken off CPAP. Mrs. Oakley replies, "Honestly, you would have to check the times for me." Mr. Myers replies, "She was stable in between these two times?" Mrs. Oakley replies, "Definitely." Mr. Myers says there is then a more marked deterioration as child D stopped breathing and Nurse Oakley called for help. Mrs. Oakley agrees. The prosecution rise once more, led by Simon Driver, to ask about the discoloration of child D's skin at 1:30 AM. He asked what it was that struck her about the rash appearance that was unusual at 1:30 AM. She replied, quote, "I had not seen it before." He asks how it had changed by 3 AM. She replies the rash wasn't as pronounced, not as bad, but she was not expecting child D to deteriorate again. She says she had previously experienced mottled appearance in babies, newborn spots or mottled, but we don't specifically get rashes in my experience. So that concludes day 20 in the trial of Nurse Lucy Letby. If you wish to keep up to date with all the trial process concerning Lucy Letby, please do give this video a thumbs up below and subscribe to the channel. You'll also see in front of you very shortly the Lucy Letby playlist, which has all of the videos concerning this case in one convenient folder. Many thanks for joining me for this video. I look forward to seeing you all again for the next one. Take care. Cheers.